Now the next topic will be by our Chief Instructor, Dr. Devendra Maheshwari. He's been propagating mix, he's practicing in Tirunelveli as a Senior Medical Officer in Arvind Eye Hospital, and he's been propagating mixed procedure throughout the country. So he's going to talk on push-your limits, GATT in angle closure and different case scenarios.
So good morning everyone, and thank you Scientific Committee for giving this opportunity to having this instruction course, especially on MIGS, especially in different situations, and really not only PAG. In this IC, we are going to discuss about the newer indications of the MIGS, especially in angle closure cases. And really we are going to discuss about what is new in MIGS, especially what newer advances. So we will discuss on the second talk. So in this talk, we are going to talk about the GATT in the PACG. Slide, please. So as the Dr. Ganesh sir already discussed about the GATT in the POAG, I think is well known. Everyone doing the GATT in the POAG. So my talk is in the GATT in the PACG. So as all we know, the MIGS become the choice of surgery all worldwide, not only in India, worldwide, especially in the economic India country like India, where we are having the multiple GATT option available. But we are looking for the options what is very economic and affordable to our country. That's why we are focusing on the TM based MIGS. So why we want to do the GATT in the PACG? Because as we know, the GATT doing the cataract extraction, some amount of the IOP drop in the angle closure cases. So when we do the cataract surgery, definitely IOP will control. But again, this if they need the further, if the optic nerve damage more, we need the further IOP reductions. So usually this is the way we proceed in PACG, and this is exciting right now. We combine with GATT with phacoemulsification, especially in the cases where we need more further IP control. So what the evidence of doing the GATT in the PACG? So we know this long-term persistent iris tubercular contact and progressive synechia could damage the TM and Slem's canal in the PACG. I think they almost similar with what happened in POAG, similar happened in the PACG. So look for the various studies and various kind of MIGS has been tried in the PACG cases also. This is long literature. So recently we come across the previous years. We are doing the synecholysis in the PACG cases. We're doing the synecholysis. But problem with this procedure, it is not effective in the cases where the chronic angle closure, the chronic elevation IOP, or the optic nerve is damaged more, or we need the target IOP lower. Then the goniosynecholysis, phacoemulsification doesn't work. So that's why we need the GATT in the PACG. I think what is a GATT already described, so I'm going to show you how to do GATT in the PACG. So I think these are some of the literature is showing the 1 year outcome of GATT in the PACG cases, but in Indian scenario we don't have the much literature. And again, this is again a study by Sarauki et al. They shows the good outcome of GATT in the PACG, and they show that at the end of 24 months they have the good IP control and reduction of the anti-glaucoma medications. So I think this pre-operative assessment is very essential. Like any other MIGS, we have to go thorough in the gonioscopy. So especially in taking the PACG case, you have to do gonio repeatedly before surgery. Sometimes we case the patient the 3 month back, 4 month back gonio, taken coming late for surgery. Even though in such cases, especially in PACG cases, we have to repeat the gonioscopy before the surgery, 1 day prior to the surgery. I think these are the instruments are required for the GATT, like the MBR knife, fiber proline suture, low temperature cautery, and I think Dr. Amit already described the various kind of lenses. We are most commonly use Swan-Jacob lenses, but Swan-Jacob quite costly lens. So right now the iPrism SX is easily available, iPrism SX available, and right now we are having the hands-free gonio. I think they are much easier in the beginning of surgery. So coming to this case scenario, so this is the 55-year-old female PACG, post PI, having the right eye having the 0.75 cup disc ratio, having the arcuate scotoma, definitely we need the IP control in the early teens. So here, so we plan for the phaco trap, but instead of phaco trap, we can do the young age, so we want to do the GATT in these cases. So this is the way we prepare the GATT suture. So this is a low temperature cautery. I will repeat again this procedure because very, very essential, especially in the angle closure case, because we don't want the tip big. If you have the big tip, it's difficult to insert because your angle is already compromised. So here we have to make the small tip in compared to the POAG cases. So this is how. So at the and throw the side put, we have to pass and see the here video. You see this is the angle really. We have to very, very thorough an angle because these anatomy in these angle are quite different from the PACG cases. So goniotomy is very, very essential to at the correct plane. Then throw the side, throw this micro forceps, just you have to insert. In PA, what is the difference between POAG and PACG? Because when we inserting the suture, and especially in PACG cases, really we feel the more resistance in such cases. And really sometime at the end, when the suture is about to come, literally sometime your suture about to bend, really have to push yourself hard to get out the suture. Though once a suture come, as we take the another end, hold it with, and just we have the rip of the tubercular mesh for 360 degree. So gentle traction, and it's at the end of the procedure, we have to wash the viscoelastic, and we have to fill the chamber with 30 to 40% with high density viscoelastic. And especially we can combine with this, we can do in a phaco case also. So this is another case where we did the phaco and the PACG. So I am skipping the phaco part. So definitely definitely in such cases, PACG cases, doing the phaco little challenging in compared to the POAG cases. So we have to keep in mind, we have to be ready with all these things. Like, so this again similar way. A good part is this. These angles are a bit open because we post PI cases, and really you have to make the goniotomy. Here we have to keep in mind that goniotomy should be in the correct plane. And sometimes these angles are quite different from the POAG cases. And similar way, just you insert the suture into the goniotomy side. And we have to, sometime we need that at least 16 to 20 pushes are required, and always mark your suture, how much the limit we have to bend. Sorry, I do not have the video, but we have to measure the suture, how was the suture. We have to bend the other side of the suture so we know how, when the bend is coming. So they give you the idea when you are going to completely suture is completing the all canal. So take the distal end again, tape it and pull it off. Then thoroughly wash the viscoelastic. After washing the viscoelastic, make the wound tight because such cases will bleed, and at the end insert the sum of the viscoelastic 30 to 40% high density. And this is the this is the case where we have the big synechias. Actually, in such cases, really we need, depends you're expert in GATT or in POAG, you can try in such cases, though they are a little bit challenging. So first of all, just you do the goniosynecholysis. You can use your iris spatula. Even I use Tanito micro also to doing the goniosynecholysis. So after doing the goniotomy, once you do the pass lead, you can see the angles, try to understand where is the trabecular mesh work, then did the goniotomy. After the goniotomy, the rest of the procedure almost similar, because once you do the goniosynecholysis, anatomy becomes obvious to you. So this is again, and deepen the chamber with the high density viscoelastic. And the other end, we take the other end, pull off in the similar way. So coming to the complications, if you compare the complication between the GATT and POAG versus PSAG, definitely you see the little bit more hypema in PSAG and compared to the POAG, little bit IP spike, IP spike and transient hypertony is more in the PSAG group in compared to the POAG. So what we should do, say there's some tips, how to pass the suture. Pass the suture first through the nasal angle at the inferior side, first 90 degree at the site of the maximum resistance we feel, and second more resistance we feel at the end where we have suture cover the almost the 300 degree. Then the last one coming out, you feel the more resistance. So what if suture stops, gently pull back with micro forceps, push the suture opposite direction and go through the another side. When we have the intraoperative bleed, so don't worry about the bleed, use the high density viscoelastic, fill it for some time and just wait for the 2 minutes, then again restart the procedure. So there is some tips I would like to share. Proline suture blunt should be the neither big nor the small. Suture end have to be tapered and make it round. Measure the total circumference of the proline suture, bend suture, have an idea, bend the suture when circumference, then have the idea how much suture is pending in the canal, and look for the blood vessels before making the corneal incision so you don't have the intraoperative obstruction in the viewing, and angle anatomy have to be well visualized and avoid the air bubble between the lens and the cornea. So GATT is an exciting option in the management of the coexisting PACG with cataract. Really, we have a lot of studies in Western population. Still, we are waiting for the result in Indian population. Thank you for patience listening.
Thank you, Devin, for the wonderful talk. So, angle closure glaucoma also now has an option